I'm thinking we might like to get going. Shall we start? Okay. So
yeah, sounds good, Ali.
Great. Thank you, Karen. So welcome everybody to our October lunchtime webinar for the Centre for Research Excellence in Strengthening Systems for Healthcare Equity, Indigenous Healthcare Equity. I'm Alison Laycock and I'm the Research Translation and Capacity Strengthening Fellow for CRE Stride. And today we're going to be talking about the important work of the Action 2 Aboriginal Kidney Care Research Project. So welcome all. But before I introduce Ronnie and Kim, I'd like to acknowledge the traditional custodians of the many lands on which we're meeting today. I'm working and living in Kaurna country in South Australia and acknowledge and pay respects to the Kaurna people and to the Widjabul-Waiable people of the Bundjalung Nation, where the CRE is based in northern New South Wales. We recognise the continuing connection to land and waters and culture of all Aboriginal and Torres Strait Islander nations and pay respect to the people in the elders past, present and in the future. And I'd also like to respectfully acknowledge the Aboriginal and Torres Strait Islander people who are amongst us today. So I'd like to introduce our presenters, Ronnie Lester and Kim O'Donnell. I'll just share a little bit of information about Ronnie and Kim. Ronnie is a First Nations woman belonging to the Anjamatana people of the Northern Flinders Ranges in South Australia. Her mother's parents are Anjamatana and her father's parents are Welsh and Tamil Indian. And Ronnie grew up heavily influenced by the guidance of her Anjamatana culture and is proud to say she's from different cultural backgrounds. Growing up in a Christian family, Ronnie grew up with a spiritual presence within her life, both from an Aboriginal and Western Christian perspective, and draws strength from both belief systems that keep her grounded as she navigates her way through life. In 2004, Ronnie was diagnosed with end-stage renal failure requiring dialysis and received a kidney from her father. In 2013, the kidney transplant rejected and Ronnie was back on dialysis for 7 years until October 2020, when she underwent her second kidney transplant, and this time from a deceased donor. Ronnie now uses her lived experience as a renal patient expert and advocate to guide and inform better clinical practice in Aboriginal kidney care. So Ronnie is an inspiring leader and role model in the communities that she lives and works across. Thanks for joining us, Ronnie. Dr. Kim O'Donnell is a mother and public health researcher who's lived and worked on Kaurna country in Adelaide for over 20 years. Kim has returned to country regularly from childhood. She's strong in her identity as a Malingapa Barkindji woman from lands in Western New South Wales. Kim graduated in 1985 as a primary school teacher. She lived and worked in the Northern Territory, or taught in the Northern Territory, mostly at Pepperminati, and taught in Dubbo, New South Wales as well. And Kim has also taught English in Japan. And she's taught jewellery making and started her own business called Namaku Jewellery that some of you may know of. In the 1990s, Kim moved back to Darwin and became a flight attendant for the next 8 years. And in this role, she did refugee charter flights into Dili during the Timorese people's fight for self-determination from Indonesia, and late night flights into Irian Jaya to the Tamaka gold mine. Kim moved to Adelaide from Darwin in 2000, where she went back to university and completed her master and doctorate degree in public health. Kim was a leader in driving the completion of the Mutawinchi Plan of Management, which is a key document to progressing Mutawinchi lands. She chaired the Mutawinchi Local Aboriginal Land Council Board from 2015 to 2019. Kim's worked on the Recognise campaign as a national field leader to raise awareness around the principles of constitutional reform, and she also co-led health policy and systems research at the Lowest Institute. So Kim's an internationally recognised researcher in Aboriginal health and wellbeing, and she co-leads Action 2 Kidney Healthcare Project in South Australia. So I'm going to hand over to Ronnie and Kim now to present and have a yarn about your work. We'll take questions at the end, but Kim and Ronnie have said they're happy to expand on things as they go through. But can I just remind you, please, to stay on mute if you're not talking. Okay, thanks. Over to you.
Good afternoon, everyone. How are we? Glad you could join us. So as our introductory went, I'm Ronnie, this is Kim, and we're here today to talk about Action Kidney Care hearing from the experts in action. So yeah, I'm going to start by introducing our message stick or our talking stick. And this was specially made for us by, you know what, I don't even remember that lady's name. I'm terrible at remembering names.
A wonderful artist, I can't remember her name too, but we will next time, in Wollonga. She made seven of these message sticks for us. So this one was made for the Action Reference team. So when we come together, we first do a spirit check with each other, and we also use these message sticks in other Indigenous reference groups that Kelly Owen, another colleague, runs and works with others.
Yeah.
I'd also like to thank Alison and Kieran for this opportunity and that wonderful introduction. And we've got the message stick, so take it away, Miss Ronnie.
All right. Nanga, Naimichi Ranina, Natuyura Michi Uchu Unakana, Natu Admat Yuratu, Natu Yata Uchu Flinders Rangers Yata, Nayuchu Aru Atu. Hi, my name's Ronnie. My Admatna name is Unakana, which means third born child or daughter who's female. And my ancestral ties are with the Admatna people of the Northern Flinders Ranges in South Australia. My moiety or skin group in Admatna is Aradu, which means north wind. So we have two, north wind and south wind, Aradu and Mathri. And it's important to know this because it helps me to understand how I relate to my family, other people, community, creation, and all other living things within. I'd like to start by paying my respects to the past, present, and future Kaurna people of Tandanyanga, place of the red kangaroo. In acknowledging the Kaurna people, we are reminded that this place was cared for and tended to by families of strong men, strong women, and strong children under the guidance and wisdom of our elders, and are reminded of the intimate and deep connection that the Kaurna people and all Aboriginal and Torres Strait Islander peoples living within Australia have with our creator spirits. We'd like to also start this conversation and this presentation by paying 1 minute silence to our brothers, sisters, aunties, uncles, nanas, poppers who have lost their battle to kidney disease. So we'd like to honour them with a 1 minute silence. All right. So our first slide takes us to the overview of our action project. And so I'll be talking about the Action 1 project outcomes, how we came together, how we found ways of working together, and how we continue to work together, and what action has actually meant to me as a patient, becoming an expert and being acknowledged as an expert for my lived experience, and how we continue to be given space and opportunity and a platform to share our stories and speak about our ways of knowing, being and doing, and how that's now being, how our voices are being brought to the forefront and being highlighted in terms of what we have to go through, the challenges that we face being renal patients, and not even just for us as renal patients, but the support that we have around us. I'm going to talk about how Action 1 helped us to transition into Action 2, and the work that was done within Action 1 really turned into, I think first it started as a space and then it just turned into this movement because of all the stories that were being shared in this space. And from the picture there, that's one of our first pictures that we took of our Action members. And we started originally with 10 Action members, and that were just invited up by Janet Kelly and Kim O'Donnell in their, I guess in their roles that they held. They were, I felt like it all just started with connections and all the different people that we was connected to, just through our family connections, our community connections in the spaces that we worked, and how we created that space to be able to come up with the things that we value and the challenges that we wanted to get through. So a lot of the work that we did within Action actually helped to identify gaps and challenges that we were facing, and then in turn it informed how we saw ourselves in that space and the cultural safety that needed to happen within the health system and how the health system was actually failing us. So the impact that Action has made has caused practices and policies to improve. Well, I've seen them improved with the work that we've done in Action, and how it's changed the SA health system that we're in now.
So thank you, Ronnie. So I'll just give you some background on Action 1. So this was a project that really put Aboriginal people with lived experience of kidney disease at the forefront. It happened, it was funded in 2018, and so it came together through clinicians and researchers who identified issues within the health system, and it gave their commitment to improving the health of Aboriginal people with renal disease. They wanted to create changes because they could see that things within the system wasn't working, and the importance of developing a culturally responsive health system that looked after and provided culturally safe care for Aboriginal and Torres Strait Islander people, particularly in trying to access assistance to transplants down the track and what that process may look like. And it was also about promoting Aboriginal community health and wellbeing. But what they found was there was no formal Aboriginal community consultation that had occurred prior to this. So they realised, well, we need to be talking with Aboriginal people and really putting at the forefront Aboriginal people's voices, particularly patients with lived experiences. And so in 2018, a group of staff from Adelaide Nursing School, Kidney Health Australia, South Australian Medical Research Institute, and the Central and Northern Renal and Transplantation Service at the Royal Adelaide Hospital worked together with renal patients to facilitate then an Aboriginal kidney care workshop at Kangawadley. And Kangawadley was suggested by the patients themselves because Kangawadley is an Aboriginal managed hostel. And when we look at Kangawadley, the building is centred around a big fire. The space, people feel safe when they go there. And so that was where the first workshop was had. Participants included Aboriginal renal patients, family members, other Kangawadley patient and family residents, and also participants and family members and carers from Ernabella, Indalkana, Campi, Freegon and Chutchanjata communities. So Action 1 established the Action Reference Team. So as a result of those formal or that consultation at Kangawadley, it said we need a reference team. We need to bring together Aboriginal people with lived experiences of renal failure. And so the Action Reference Group was established. That's around the time I came on board to support and play a bit of a secretariat role at that time with my colleague, Dr. Janet Kelly, who was able to access funding through MRFF funding. So, and also that was auspiced through Health Translation SA. So we established the Action Reference Group, and that came together primarily from the relational networks that some of the kidney nurses had, the nephrologist kidney doctors, through Janet's connections also with other clinicians, through my connections. So the importance of the relational networks really was a catalyst, I think, in bringing the team together. We had 3 community consultations at Adelaide, Port Augusta, Ceduna. And from those 3 consultations, we had reports that were written, and they informed the inaugural National Indigenous Kidney Care Clinical Guidelines, because there wasn't any in terms of working with Aboriginal and Torres Strait Islander people. So then the patient journey mapping happened, and the patient journey mapping tools were developed in 2008 from Managing Two Worlds Together. And that was also a project that was supported and funded by the Lowage Institute. And so from those patient journey mapping tools, we're able to map each reference team member's stories from when they leave home to access through the healthcare system and then back home again. So from those tools, you're able to then see where the gaps were in service delivery. And sometimes some of those gaps might just be a communication gap, you know, language barriers, but also, you know, people have experienced racism and what felt like racism to them by individual healthcare members, you know, say. So those patient journey mapping tools now have been they've been redesigned, and that's also another piece of work that we did from with the Lowage Institute. We've had 2 annual key stakeholder workshops. The first one was in 2019, and then again in 2020. And what was identified from those workshops with our stakeholders was the issues with accommodation and transport, which we all knew, everyone was talking about it, but it was actually formalised, and so they were the 2 areas that we focused on, I think, in Action 1. We also were able to change and influence the model of care. So now we have dialysis at Kangawadley. So because people, it was difficult, it's very difficult accessing the healthcare system through the hospitals. It's a bit like a minefield. And so people were feeling really comfortable to go and have dialysis at Kangawadley. So there were 2 chairs set up there, which are currently being evaluated. So some of our members also sit on the evaluation team for that. And that's due to, that's going to be expanded soon. So we've done a lot, haven't we?
Oh, yeah. Yeah, there's some good outcomes.
We've covered a lot. Yeah. Am I doing the right thing here? How come it's not moving forward, Tel? Just a slight technicality. Oh, we got stuck here.
Oh, there we go.
Here we go. So did you want to talk to this, or are you happy?
Yeah, well, just some of the Action 1 outcomes, which Kim's talked about, as well as the update of patient journey mapping tools that was developed, as she said. But that's really helped to tell stories in a clear way, to see where the patient started, what has been the challenges along the way, and what outcomes and help and support they've received as well, and the different interactions they've had along the way with the services. So it really highlights the good experiences they've had and the bad experiences they've had, and how we need to get all their experiences in the green so that it can be a good experience for them. The cultural bias and policy report, which is yet to be published. A lot of work and words and stories captured in that have come from the action group and the action project. And we hear stories all the time of our mob being treated poorly or treated unfairly, and how that impacts how they access services and even their willingness to come back and access the service. So we want our people to be accessing the services so that it's safe.
But in the cultural bias and policy reports that we did, we also looked at the literature that were of people and groups that have worked in this space to improve the models of care for renal patients across the country. And we used the literature of programs that were evaluated. And so that report, we're actually waiting for that to be published because that's got a lot of rich knowledge, and which came from the stories also from another colleague, Kelly Owen, who is the National Engagement Coordinator for the National Indigenous Transplantation Task Force. So we're looking forward to when that cultural bias report and policy report comes out, because we are hoping that that's going to influence the Commonwealth Government to work, I guess, much better in this space, and to support and walk alongside people who know about their bodies and people who've experienced the system.
We know the experts.
Yeah.
The experts. Yeah.
And then in December 2020, so last year, Janet and I and amazing researchers and clinicians and doctors that have worked and know patients for a long, long time, we came together and we had a crack at applying for the Ideas Grant. It was a 5-year funded grant, and the Ideas Grant, and we thought, well, let's flip this, and let's look at power, and let's look at control, and shifting things around a bit so that we were able to have more influence in terms of Indigenous governance, but also to really flip it on its head. So we worked really, really hard to put in that report with the support of our colleagues, Dr. Tamara McKean, Dr. Odette Pearson, Shilpa, Stephen McDonald. So it was an amazing thing, because the funding for Action 1 was only a 12-month funded project. You can't really achieve much in 12 months, but we had a good crack, and I think we've done really, really well. And so with the impact of COVID also, but that project was extended, but it didn't necessarily come with extra funds. So we had to really manage what we were doing there, and but it worked. And so we got a phone call, or we got the email in December. I think it was around the 5th of December.
And had to keep it hush hush.
Last year we had to keep it hush hush, because it hadn't gone out in the media. And oh my God, I think the first thing I just cried. I was overwhelmed. So it just meant that we can continue this work for the next 5 years.
And I think as a patient expert in this space as well, to have the work that we've done over the last 12 months being acknowledged and further supported through this kind of funding, for me, that was like people are listening to it, people are seeing, we're being seen, we're being heard, and our voice, like we as human beings, are being taken seriously. So like I feel valued now in this space, and it all comes back to that, supporting strong Indigenous governments and governments, self-empowerment, self-determination. So you're sitting at our table now. So that's the flipping of the head that we're talking about. So we're not sitting at the table of the decision makers. We created our own table, or our own campfire, and we sitting at the campfire, and we're inviting people to join us to sit there to see how we're doing it, to see our ways of knowing, being, and doing. Yeah. So then this leads us into our research team's journey map, which Janet and Kelly had a lot of fun in creating and putting together, and trying to figure out how it's going to look, and without confusing everybody. And this is basically a snapshot of like who are the people involved in action, what some of our values and our main areas of focus are, the people that we're connecting in with and building relationships with, and then how it all transitions into Action 2. So in this slide, we've highlighted this building relationships and trust section, which I'll talk about. And Action 1 for us has been a brave space, a space where we get to come together, feel safe, be supported. As renal patients, we get to share our experiences, not even just for us as patients, but the people supporting us. So we've got carers as part of the team, and families that come along that have been there with our journey through the health system. So it's to lead and have discussions to unpack at a deeper level what's happening in kidney journeys in general, individually, with our lived experience and what we wanted to change. And so we started by building on the elevated work already done in the renal space, and the outcomes being the cultural bias and policy reports, and just inviting people into this space. All those connections started to just happen once they heard the story and connected a dot. It was like, we do work in that area, we can help you. How do we connect with you? So then all these little connections started to happen, and we drew on our kidney and relational networks where, we had people that we trusted, we had people that we knew that were sitting at the decision-making table, people starting their journeys, clinicians who knew what they were doing and that have worked in this space with our people for a long time, but also people that were, willing to take a risk, get uncomfortable, and come willing to learn from us. So sometimes I found that we've always had to go into a space, but we've had to physically go into the space. And now, flipping that table again, like we're bringing people into our space where we feel more supported and able to lead the project. So we've identified the need to do better, and those working with us have also identified the need to do better in Aboriginal kidney care. People who have been invested in bringing care back into the health system, our renal kidney leaders and staff that we've known, that our patients, our experts have known for the last 10 years. So we've had, prior to Action 1, we were doing things individually as patient experts, but we didn't have this whole network that we do now that Action 1 has provided. It was just us doing our own little network, trying to make small changes just in our own realities. And that, you can only get so far with that model. So Action 1 has actually provided this really strong foundation, a strong model that's led by us, like the stories are from us, it's our lived experience, and people are invested in it, which tells me that they're invested in me as a human being to live a better quality of life, given the cards that I've been dealt with in life being kidney failure. So yeah, it's been pretty important space for us to be in.
So this is, for me, it's been really interesting mapping where Action 1 has come from and how it's influenced and the ways we're working into Action 2. So on the left-hand side, you'll see these are our stakeholders in Action 1. So we worked quite closely with SAMRI, the South Australian Health and Medical Research Institute, National Indigenous Kidney Transplant Task Force, Aboriginal Health Service, Kidney Health Australia, Purple House. We've also made wonderful connections with the reference teams up in Darwin and Alice Springs. And so shifting into Action 2, which is a highlighted area there, we wanted to, we had lots and lots of circular discussions around the importance of collaboration and what did that look like in practice, and then how do we make our voices heard, and how do we raise the voices of our patient experts and families. And so we work with the story of Gama, the knowledge sharing, and that was a beautiful concept from the Yolngu people in Northern Territory, and I've been working with that concept for quite some time, since about 2004 or 5. And then we're also working with the concept around Dadiri, which is a deep listening from the Nungi Kurungu people around Daly River, which is interesting because that's where I first taught when I, straight out of university when I was about 21, 22. And so these were wonderful, really deep First Nation concepts. And then yarning, to have that relaxed conversation, which is what we want to do here, is to be able to, we'll bring formal and informal together. And that's in that intercultural space, or that crossover, the interface we were calling it. So we were calling it the interface and working in brave spaces, because when people work in this space, there are if you're willing to learn, there will be many times when you're feeling vulnerable, and then it sort of was more around how do we support each other in those ways too. But we wanted to combine Indigenous and Western concepts and then to co-design a culturally safe model of care for renal patients. And we wanted to bring back collective decision making. And this is a participatory action research project because we ensure that we always come back to the reference team. We always loop back to our research team. We loop back to our action project team and our stakeholders. And so that's really important and based on look and listen, think and discuss and taking action together. And then we want to sort of mix it with sometimes, interviews, focus groups, surveys, evaluation, and then the critical reflection is really important, really important. And so when we talk about critical reflection, like sometimes after we have action reference team meetings and we have guests come in or there's new members coming into the group, there'll always be a connection. Someone will know someone. It is just that's the survival technique, I suppose, or the survival ways of working with Aboriginal people. You always had to be connected, and you always had to have and work on those relational networks in order to survive in a colonial space. So there's always these little windows of opportunities or unexpected outcomes that we have, and so we're also mindful to record those stories and what happens, because that's all the invisible work that happens behind the scenes. So, and sometimes that shifts our thinking, or it might shift the way we're going. So, so what was identified in Action 1 was we've got 4 sub-studies or four little projects. And over that project, we've started Indigenous Governance, and we've already, that's what we're doing now. We're working out and putting what it is we want, how do we want these teams to operate in our working together agreement. So Indigenous Governance is what patients told us about, and they said, I think these are your words actually, Ronnie, we are more than our disease. We don't want to be looked at as just patients with disease. We are more than our disease. Our kidney issues are just a part of what we are, but we are strong people. And then we have the kidney journey mapping of patient journeys and stories, and these tools have also been used in other areas also to make visible the work that renal kidney managers do to bring people together to have access to dialysis and to get them back to country. That's not necessarily seen or ticker boxed in the health system. And then it was really important, the support for Aboriginal kidney care patients. We know what it's like. We want to, as Ronnie said, we know what it's like. We want to create the resources and create these resources to promote health, to keep people healthy, and then to create the resources that will help people who've been recently diagnosed to work through the system.
We know how to connect best with our people and the information that needs to be shared. So it's about creating resources that our people are going to pick up, read, and be like, I can understand this. I'm going to look into this. So it's just about having access, them having access, and them understanding, and them connecting.
And so then our end goals is what we want. We want to have patients and families with better kidney care. We want to have dialysis and transplant experiences and outcomes to be good, to be healthy outcomes, and access and education and prevention resources and peer support, and also the health professionals to be able to, and which has already started to create and have input into cultural safety training and tools, and the health journey mapping tools are primarily developed for clinicians, but they have been used in other settings, and so effective partnerships, and to change the way, to bring care back into the healthcare system, to actually have input into and co-design a culturally safe models of care for Aboriginal and Torres Strait Islander people, and that may look different around the country.
So our progress. So I guess what Action has been able to achieve, so within the first 3 years, is establish those relational networks. And yeah, so just providing that space has been able to create all these networks. So the space that Action gives us, people are connecting in with it, and then we're able to just connect those dots, continue to work with our key organisational networks. And so we have within Action 2 now, we've identified all these different little groups. I like to say acronyms because they're all their art, their act, their ask, all these different little acronyms that we're getting confused about now. But it just goes to show like how Action, just that one little network of Action, has now become these little pockets of support that we can tap into at, you know, whenever something arises. We connect with, we've got people in this space over here that we can talk to. So that's really good to have. We're now progressing the Indigenous governance structures, and that's been interesting to look at, because whenever we come into our meetings and whenever we're doing presentations or even the preparation, we're always things are being highlighted for us of what doesn't work when we're doing it a Wood News way, or the Western Wood News is white person or non-Indigenous person in my language. But when we're doing it in the Western way, we come against so many roadblocks and things that just stress us out. And then when we flip it and do it our way, it's like, why can't we just do it this way in the first place? So it's made our, you know, how we process things, decision-making process, how we see ourselves in leadership, even the confidence it gives us to be able to sit here and be in this brave space and talk about it. Like, I feel more supported knowing that I can come in here and do it our way. It's more sustainable for me. We're being held accountable because we're coming from our perspective, and there's more transparency when we're talking from our lived experience and doing it our way. Like, I feel confident to be able to sit here and do it my way. So we're in the process of drafting our working together agreement, which will help us guide our work over the next 5 years. And it's a living document. So it's not a document we say, okay, yep, tick, that's how we're going to work together. We know that there's going to be challenges and changes that happen along the way. And, you know, we know from our experience that a patient expert can have 5 million things happen to them in the space of 24 hours, which could affect or impact how we continue to work together. So we're always mindful of the different energies that are in the space and how we cater to be inclusive of and highlight their voices and make sure that, you know, no one is left out and that we're not tracking on without people. So Action Croaky articles are also about to be released, and so we're looking forward. So keep your eyes out open for those, because it's going to tell you a lot more about in-depth stories of what's been happening in this space from a patient expert's point of view, and working collaboratively now on position descriptions of each team member. So yeah, it's been a slow process, but it's also been quite fast in terms of, you know, when you're living in the city compared to when you're living in the country. And we talk about that often, about, you know, the fast pace of the city and how everything's on the go all the time, and then you go back to country and you can sort of slow down and you know, like take everything in and be like, oh yeah, this is what I need to do. But it's been good to see the progress, and that we're actually making progress, and that it's actually, you know, I can see how the work of Action 1 and now Action 2 is flipping the service on its head, which allows us to become more impactful decision makers. Do you want to add anything to that one?
No, I think you've covered that. So Ronnie's mentioned the working together agreement. So in Action 1, when we first got together, it was really important. And the document at the time was, I think it was maybe a 2 or 3 pager, and it was, we call it the terms of reference. And then, you know, the team members said, oh, you know, terms of reference, let's call it working together. And I said, yeah, okay, that's really what we're doing. So we had a terms of reference, and it was important to set that up with the reference team, because we wanted to be really clear about how we were going to be operating, or how we wanted the space to be. So we talked and we had principles about discussions and the relationship. So it was based on a set of principles that would keep that space safe. We also looked at the importance of having Nanga space, Aboriginal space, Black space. And that was really important because sometimes there's issues and things that come up that really warrants the need for Aboriginal people just to get together and be with each other, to support each other. And I'm talking about lots of sorry business. So you're talking about intergenerational trauma, you're talking about constant sorry business. So it was really important for us to have that space to check on each other, just to be with each other, to provide support, and then also have, some of the discussions that we needed to have if we had pushback on things that we'd suggested needed to change. And that was really important because, when you're working in the academic space, you're working within, the colonial system, and it is, the system was set up. It was not set up with First Nation people in mind. So it's quite a juggle, isn't it, Ron, to work within the system and then try to create change from within. At the same time, keep your own spirit strong in terms of your identity and where you're coming from, and then managing all the sorry business. And that's the invisible stuff that I think a lot of people don't understand, the management of sorry business, but also the management of our own families that may have mental health issues. And so it was really important to have that time. So coming into Action 2, we have alternate space. We talk to the members and say, do you want closed space, open space, next one? So we're trying to alternate when we have those spaces, and then what people want to talk about. So the terms of reference document's gone from a 3-pager now because we've got quite a few teams, as Ronnie mentioned. We've got the Action Project team. So now we're trying to clearly define what the role of the Action Project team is. We've got Art, Action Reference team and their role. So the whole project centres around them. Then we've got the Action Research team and chief investigators and associate investigators. So we're now trying to make sure that we have clear definitions of each group and their roles and responsibilities. We're looking at developing the principles for that. And one of the main principles which came up is the sense of humour. You can't work in this space if you lose your sense of humour. That's, as you said that before, and as Shilpa, one of our kidney doctors said, humour is a superpower. If we lose that sense of humour, it's really hard to get back on track. So that's one of our, one of our strong principles is that sense of humour when people's spirits need to be lifted. And so this next working together agreement is a thicker document, and we want to be really clear on the definitions. If we're using cultural safety, there's a lot of definitions out there. If we're using Indigenous governance, what do we mean by that? But we want to make sure that we're clear on the definitions within these documents in the context of our work. And so we're working on that at the moment, and really trying to flatten that hierarchy, that top-down structure, to a flat, more of a networking way of working. And it's interesting because when we reflect on leadership, well, what does that look like in this space? You don't have just one person leading this. I might be the chief investigator leading this on paper with the National Health and Medical Research Council funding. But in terms of the project, leadership comes in different forms depending on the skill set of that person. So it's an adaptive, I think, an adaptive sort of leadership style. So I guess also the other important point with the Action Reference team is we support them, and we've built into the budget. They have transport access to come to the meetings. It was difficult to actually get some at the beginning. We have vouchers. We introduced vouchers as a way to be able to pay people straight away because of the admin system within the university. It's slow and long. Now we've got chief investigators on board. Ronnie's here with us. So we've got contracts coming through. A new contract, I think, is complete now. So so our colleagues and the clinicians and doctors, when we do come up against these barriers, we try and figure out, well, how do we get around this? How can we change this? How do we keep moving forward? They're really instrumental in pushing and protecting us in that way too, I think. Yeah. So the working together agreement is a work in progress, and we've got a closed session in a couple of weeks or 3 weeks time to just primarily focus on getting that document to a good decent draft stage to then send out to our groups and then workshop that again.
And our hope is that everyone will sign that document and will agree to work by its terms, and will give us feedback along the way about if the document works for them in terms of how we work together.
Yeah, and it's about being accountable and transparent to each other in the next 5 years, you know, and we do walk on shifting ground.
All the time.
So all the time, yeah. COVID's just, well,
Made it that way.
made it even more challenging. And so, do you want to?
This is a team that we're working with together over the next 5 years. And this is people that we've worked with in Action 1 and continue to work with in Action 2. So in Action 1, the renal patient experts began as reference group members, and there was only one Indigenous chief investigator, Dr. Odette Pearson, and there was intended to be 2, but it wasn't possible in the end. So yeah, in Action 2, there are now 4 Indigenous chief investigators, including 3 renal patient experts, which is, you know, a pretty major thing for us. Like when we're told, oh, you're a CR, we're like, what does that
What's
even
that?
mean?
What's
What
a
does
chief
that even mean?
investigator? What do you mean by that?
Yeah. So the kidney doctors and nurses, managers, and experienced researchers in Action 1 have moved to a support role and associate investigators, which means that it's really top heavy led by Indigenous experts, people who live it, breathe it, we know it, we are it.
And you know the strategies that need to be put in, need. And so, yeah, you know what needs to happen. But I guess having, you know, people sitting in positions of power like Stephen McDonald and Shilpa and other nurses who can make some changes, and sometimes some of the changes that need to be made is just a communication problem.
And you can even see just in that little slide there, just how, you know, Action 1, who the leadership was, and then you look at Action 2, and what we wanted from Action 1 was that Indigenous leadership, Indigenous voice enshrined, you know, that self-empowerment, self-determination. Action 2 clearly shows that this is Indigenous led, this is Indigenous governance, it's a living Indigenous governance. So we're working it out as we go along as well.
Yeah. So and there's going to, you know, you will always come up against issues and challenges, but it's really important that we're able to sit openly and talk about things. But I think to have that black space for our researchers and also for the kidney patient experts is really important. It's quite a supportive space. So watch this space in the future. It's certainly interesting times for us. And when we sort of look at, well, what is it about this brave space? You know, what's the energy about this space, and what does collaboration look like for us, and where do we want to go with it? So we would like to leave you with this poem, and this is really summarises how we're trying to hold that space and work in a collaborative way. So this is an invitation to brave space by Mickey Scott Bay Jones. Together we will create brave space, because there is no such thing as a safe space. We exist in the real world, we all carry scars, and we have all caused wounds. In this space, we seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect. This space will not be perfect. It will not always be what we wish it to be, but it will be our brave space together, and we will work on it side by side. And side by side in Barkadji language means wikara. And I often say we work on it wikara way, side by side or alongside each other. So we'd like to leave you with that poem, but we'd also like to leave you with this picture here.
Yeah,
Oh,
we like to take lots of photos as a way of recording our work and documenting. So this is most of our action team and how we work. And once again, humour is our superpower. So with our photos, we always do like the serious, yes, this is us working, we're doing it. We're actually working.
You do the formal
and then
photo.
we do our silly one. So we go a bit crazy in some of our photos. But in this photo, that's me on the computer screen. I wasn't able to make this action meeting because I'd actually just had a transplant.
Oh, you were gonna
No, this is pre-transplant. So I was getting ready to go in.
She was in the hospital next door, getting ready to go in.
So I'm getting ready to go in for transplant in this photo. And all the guys are like, you know, supporting and still making me feel like part of the team with the power of technology, which is we love using technology for humour.
We do. And that's Sam Bateman on the left there, standing up behind on the left. And Sam's one of our nephrologists, kidney doctors. She's amazing. She's doing a PhD. She works closely with Kelly in front of her there in the brown shirt. And Kelly is the National Indigenous Transplant Task Force Coordinator with Shilpa. And then we have the beautiful Kate on the right side of Kelly at the back there. Kate's now working on the APY lands and she's been there for, didn't she get that job early this year?
This year, yep.
And then we have the amazing Nari sitting in front of Kelly there in the wheelchair. That's Nari. She's a force to be reckoned with. And it was Nari and Inawinchi standing to the right of Nari. So these two, that actually were the first to start the reference team, really. And Nari's been known to run down politicians in her wheelchair if she's not satisfied with the answers she receives when she asks questions. And then you've got Janet Kelly on the right of Inawinchi, myself. Donna is a single mum, and Donna is the cousin to a young member we had that we lost a couple of years ago. And then you've got Jared, who's also on the right there, that's had his transplant. Is this coming up? October?
It's coming up November.
So he had
2 years.
Yeah, okay.
So it's his 2-year anniversary in November. Mine is in 2 days, my 1-year anniversary for transplant. And I think, when's Kelly's?
Kelly's is Sorry Day.
Sorry,
so Kelly got her transplant on Sorry Day, which has become her happy day.
I'm sorry, his kidney.
Yeah, I'm sorry, he's a kidney. Yeah, maybe. So we try to celebrate the transplant days and birthdays. And as you can see, we always like to have fun. This was a particular day where we had our action reference group meeting, and everyone was wondering where Ronnie was. And so Kelly was on her way to pick up Ronnie, and Kelly arrives at Ronnie's door early in the morning and says, "Come on, Ronnie, you're ready to go to our meeting." And Ronnie's going, "I've got a kidney." And Kelly just thought that it was a kidney art piece that Ronnie and Jared were working on, 2 kidney art pieces using the plastics from the dialysis machines. And Ronnie was actually saying, I've got a kidney, I've got to go to the hospital. So halfway on the road, Kelly pinged and said, "Oh my God, what? You've got a kidney." So then Kelly took Ronnie straight to the hospital. And then we were all sitting here waiting, "Well, where's Ronnie?" And then of course, it was just an amazing day. It was funny. Anyway, so that's us. That's the presentation, and we're open to have any questions from anybody. Thank you for having us.
Oh, I've got a friend here. Hi, Brooke.
Oh,
yeah.
Here we go.
I went to school with Brooke in Port Augusta.
Oh,
yeah.
Yeah.
So we're just having a look at our comments here now.
Okay.
Big screen. Do I go stop share? Hey, how do I do that?
What are you doing?
Stop share. There we go.
Okay.
Is that it? Oh, okay. There we go.
Great.
Oh, look at Kelly. Oh, this is lovely. Wow, you can see everyone there.
Yeah.
Nice. So
Thank
So
you.
Alison, do you feel, yeah, we'll take you back, give you back to Alison.
Oh, just to say thank you so much for
Oh,
such an
Sam,
inspiring
baby Augie.
presentation and sharing your important work and your stories. We do have a bit of time for questions and we can stay online a bit longer. It was wonderful. Thank you. And we'll have a look at those comments on the side. While we do that, I noticed, Emma, a little while ago that you had your hand up. Did you have a question?
Emma.
Me, Emma? No, I have my hand up. I don't know what I was waving.
Ah, okay. I beg your pardon, Emma. Okay. All right. All right. So we can open you up for questions.
I think Scylla had a hand up, Ali.
Yeah.
Okay.
Thank you, ladies. That was such a wonderful presentation. I love the renal empowerment voices finally being created in such a space where patients, a group of patients, have a lot of power. I've been in the renal space for a long time now, first as a volunteer. I was a diabetes health worker at Wuchopran, but as your reference group will actually find out that, you know, there aren't a lot of support systems around nationally. And if this is the beginning of something big, which it sounds like, I'm definitely really supportive and 100% behind you guys. I've been on dialysis now for 9 years. Was up for a transplant, but that's another story. When I have a long time to have a yarn with you guys, I will tell you about my stories. Just in relation to your cultural bias and policy report, is that just about racism? Because we've had a big racism report here in Queensland, and that was done in 2017, and it's just going into the hospital government system now for Quake, our national peak body for Aboriginal and Torres Strait Islander community control, to try and work with Queensland Health to disseminate some of the barriers that we find in the hospital systems. And when you narrow it down to the renal space, you know, I think it is about empowerment, and the way you learn that is about, for me personally, is asking questions. And that way it empowers me. I mean, I've got a Master's of Health Research all about renal disease, where I worked with 12 renal patients in Brisbane, but I've worked with hundreds of patients nationally around Australia on impact study, looking at barriers to kidney transplants for Aboriginal and Torres Strait Islander people. But I think the renal space, wherever you are in Australia, it might be good in some areas, but in some other areas, it needs a whole shake-up. It needs nurses to have cultural training, cultural competency, respect for patients. You know, when you ask them a question about when you see an Aboriginal lady getting needled 10 times up her arm, then you speak up on behalf of that patient. What's your needling protocol? And the nurses challenge you. And I just find that really disturbing, because if you're not looking after our own mob, how on earth are these non-Indigenous nurses looking after our mob on the machine? So there's a whole gamut of areas, I think, in the clinical space as well, that we need to challenge people on. And through your reference group, I hope some empowerment comes of that, where they can challenge the tertiary system and feel strong about it. So I'm very interested in your whole work and your partnerships that you've developed, and the work you've done on Action 1. So great work. And yeah. So yeah, that was just a little question about your cultural bias and policy report. I do encourage you to get that published as soon as possible, so that way some governments can start to, you know, have a look at the outside picture, you know, just not from their tertiary world and their clinical world where they come from, where the patients are always wrong. Thank you.
Thank you, Scylla. Yes, the cultural bias report, we were under quite a lot of pressure to complete that in December last year. When we were asked to do the report, it was around cultural bias. And so the first discussion we had was, well, what do they mean by cultural bias? For me, I just sort of thought, well, is that another warm and fuzzy word for racism? Is that you know? So we've had lots of circular discussions, but that report is now, and that was funded by the Lowitja Institute. So we are awaiting that to be released. The National Indigenous Kidney Task Force have responded to that, and so we're hoping that'll be released in the next couple of weeks. But there's certainly been pressure by the Lowitja Institute to put it out there, because that does have a policy report and it does have recommendations and lots of lived experience and stories. And needling was certainly one of those stories, Scylla.
Yeah.
So that came back again to the reference team for further discussions. There's quite a lot of recommendations in there, and then that was narrowed down to the top, I think it was top 6 or top 12 recommendations that the reference team wanted government to take note of. So hopefully that'll be out soon.
Okay, thank you.
Thank you. Do we have some other comments or questions? Okay.
Yes, it's Megan Passy here. I work at the UCRH in Lismore, and I was just wondering if, when that report comes out, could you circulate it through the Stride network? Because I'd be really interested to read it. Assuming it's free to be distributed.
And it'll be released, it'll be put onto the Lowitja Institute website as well. But yeah, we'll send it. Oh, don't you worry. Don't you worry me. We'll be sending that all around the country. And I wanted to just say too, we do have an international connection in action too. We have one of our chief investigators is José Lavoie, and she's worked with First Nation peoples in Canada for over 20 years and has travelled around Australia and has done some work here as well. So the First Nation communities are also really keen to see the update of the health journey mapping tools, but they're also quite keen to be looking at that report as well. So we do share resources with First Nation peoples. There's also an international a team that we meet up with as well on a regular basis. And at the end of the day, there's so many great resources and there's things that people are doing that we should be sharing. Our culture sits on the foundation of sharing knowledge, but it sort of butts up against that, that this knowledge is mine, and it's my intellectual property right. It's quite interesting managing that space as well. But yeah, look, we're happy to share whatever resources we have and to meet and talk further with others about how we're doing things. Did you want anything else to say there about that, Miss Ron?
You got that one.
Okay. Thank you.
Thank you. And we'd be very happy to be distributing things through our network. That would be just fantastic to keep in, to be able to do that. Kelly, did you have your hand up?
Thank you. Kaya from Perth. I just wanted to let everybody know basically the update with the cultural bias report. Katie's online. She's our NIC senior project officer, but the microphone isn't working. So we're just letting you know that there is a release happening in November and next steps, and that we can distribute to anybody who would like it. But like Kim said, it's on the Lowitja. It will be on the Lowitja website as well.
Great. Thank you. Okay. Do we have other questions or comments?
Just one more from me, from Scylla.
Mm-hmm.
Just in regards to your change model of care, doing dialysis in the hostel, how did you go about that and get the funding for that? Given are the patients not acute patients? They're quite stable, so they're able to stay, do their dialysis at the hostel without a medical team around or a nephrology team around? How did that come about? Because that's really interesting. That's a really interesting model.
I feel like it started with conversations around having a one-stop shop for Aboriginal and Torres Strait Islander patients coming into the city from country and accessing a service or a place that was culturally safe, and that they didn't have to go here, there. And so this was a constant challenge and story that kept coming up in our initial conversations. And so we started to sort of connect some dots and think about, well, okay, how can we make an immediate impact and change in this area? So, and then we just started to just think and talk about it, and then it led to.
Yeah, so look, I'm probably going to ask Janet Kelly, colleague. You there, Janet? You can hear us. I'm gonna ask Janet Kelly to talk to this. So because Janet
She really led that.
originally started we'll sort the funding in the early days, and I think through the clinical connections with staff that Janet had. Did you want to talk to that, Janet? I'm happy to.
Yeah, I can. And this feeds into what Kim and Ronnie were saying before about bringing all the people together. So we had the really strong community voice that identified this was a really big priority, and it came out of all the consultations, the journey mapping, all of our meetings of the reference group. Meanwhile, the renal services were also looking, they were really concerned about what was happening for people from remote areas, and people were missing dialysis, getting really sick, and there are emergency admissions. So they were crunching their data and building a business case. So these two came together, and then Stephen McDonald, who we talk about, who arranges dialysis, Stephen did a lot of that really high level work, because to have the dialysis set up, they had to negotiate across 2 different local health networks, which sounds easy, but is actually really difficult. So he did a lot of that behind the scenes work. So it was a coming together of all these groups, and then the hostel manager, the Aboriginal managers who wanted to know that community were really behind this. So he came to the reference group meetings and said, well, if we do this, how do we explain to community who will actually get access to this dialysis? And I remember, Ronnie, you said, that's okay, we can help explain this. We can help explain those people who most need to have dialysis here, because they're the ones who are really struggling in Adelaide at the moment, and they're missing dialysis and they're getting really sick, and then they get put in the ambulance and taken to the hospital. So all these different things came together, and that's what made it work.
And again, like we talk about that importance of the space and having that space, because we wouldn't have heard the stories about this need without the action space. So again, the importance of creating space to hear the stories is something that we really value, and that we try to continue with action too.
The other thing we do, Scylla, and it just, it happens, like sometimes, I'll give you an example, if you don't mind me using it.
Yeah.
So, Ronnie may have family members that have just been diagnosed with end-stage kidney disease. And so she might give myself or Kelly or a call from, and say, hey, so-and-so's in the hospital, and we're just right next door. Can you just go and check on him or her? Just go and be with them. They've just been diagnosed, and so it's not uncommon for us to go, okay, yep, we've got this. So we'll go over and be with patients, prior to COVID, but also, when we can. And so that's the sorts of things that happen as well, and that's that invisible work. There's also other situations where a member may have experienced, what they see as racism or stereotyping, and rude clinicians, and they'll give us a call and say, well, I'm just trying to get this happening. This happened to me. This is what happened, and so we can then Janet. Or perhaps Sam could then make a call, or then they're able to step forward and go, we've got this, we're going to find out what happened. And so that's that's the support from the clinicians and other colleagues. So it's that, as another colleague said, Pennies, it's just like working in this space. It's like, well, you're knowing when to step forward, knowing when to walk alongside, knowing when to step behind. And that's the kind of actions that we juggle in this at the interface. So, you know, there's times where I might raise an issue, but it'll just, you know, it may just look like, oh, here we go, another black woman whinging about something. Whereas we think a bit more strategic, we go, okay, well, I think we're going to have a better outcome if you raise this issue, Janet, or someone else raises this issue. And so that's what happens. So someone else, you know, our colleagues will raise a decision, and that's kind of how we maneuver and work within the system. Yeah. Is there anything else? I was rabbiting on a bit there. I just tend to rabbit on, eh? When you get the platform, eh? You rabbit on.
I don't think this is rabbiting on, Kim. It's a fabulous presentation, and we've had so much wonderful learning and sharing, and thank you very much. Are there other questions? I know we've gone over time, but I think as long as people have things they want to talk about, that's fine for us. Are there other questions or comments for Kim and Ronnie? There's a hand up over there.
Just Janet here again. Scylla, I realised I didn't answer the other half of your question, which was around how the dialysis is set up in Kangawadli. So there's a nurse allocated there, and I've had Aboriginal health practitioners and a nurse work together, and there's a nephrologist who's allocated to that clinic as well, and she often does remote clinics. So she is from she already has a relationship with a lot of the people who go to Kangawadli, because she's already met them out in their home country and when they come down to the city. So there's quite a wraparound. And during COVID, the Aboriginal hostel were making sure there was a lot of other services, and the local Aboriginal primary healthcare service, like there's a lot of wraparound all coming together around people. Yeah.
Thanks, Janet. Okay. Well, we probably regretfully should wind up now. It's been absolutely wonderful presentation. Thank you. Great opportunity to talk about this and really important work you're doing. And what I'm going to do now is just hand over to Karen, who's going to talk a little bit about the follow-up and how to access this, the recording afterwards.
Yeah, thanks, Sally. And thank you so much, Kim and Ronnie. That was just incredible presentation. I feel like I've so much in this hour, and you're doing incredible work. And yeah, thank you for sharing it. Thank you for sharing it. So if you're happy to, we'll share maybe your email addresses with everyone here so they can stay in touch. And we've also recorded the session today, so we'll send a link out to everyone so you can rewatch this or send it on to colleagues that want to listen to the amazing work that Kim and Ronnie are doing over at Action. So.
Oh, we're not doing this by ourselves. It's a whole team behind us. There's about 6 little teams behind us. Oh, we got a mob. Pretty big. We got a mob. Yeah, there's a whole network of people that we'd like to thank, and we'd like to thank Stride for giving us the opportunity to share what we're doing.
Yeah,
so thank you very much.
Thank you. And you've got a Croaky article coming out soon, yeah? So if you want to share.
Coming up actually, so yeah, watch that space.
They're good reads. Yes, we had to read it before it got approved. So yeah, it just explains a bit more further into the stories from the lived experience. So yeah, make sure you look out for them when they come, but it's always empowering to share the story and to bring people along the ride for the journey as well and create more connections, because it just builds the platform for action even stronger, and real action happens.
And we'd like to thank Penny Smith and Croaky team for actually giving us the opportunity to get our stories out there.
And to our amazing team too, that we know is here supporting us as well.
Yeah. You know who you are. Thank you. Bye-bye, everyone.
Thank you so much.
Thank you very much.